Over to you.
Now, um, I'm sorry, I mean, we didn't have an introductory beginning actually. I think if you don't mind, can each of you give a short introduction of what you do, who you are, and all that?
Yeah, those are given by Sweet PM.
Already given? Okay. Not that, about the participants, I mean.
Yeah, these are okay. About the participant.
Yeah, quickly, just the name and what they
There
do.
are 51 participants on this batch, Shankar.
Yeah, 31 I can see.
Yeah, there are mixed participants from the retired government officials, doctors as well.
Yeah.
Okay, and there is our national facilitator Sunanda also with us.
Uh-huh.
She will be coordinating throughout our sessions. She will be helping out throughout the sessions for
Okay.
participant sites.
Ah,
Okay, good. Is that enough?
okay. Mm.
Uncle, actually, all the participants have been coordinated by Dr. Asha Deshmukh, who is a very passionate professional herself.
Okay.
So she had brought in all the professionals from, I believe, Dr. Asha, if I'm correct, you are from Pune, right?
No, from Nasik.
From Nasik, correct.
Yeah.
So she's from Nasik, and all other participants are, majority of them are from Nasik.
Uh-huh.
Some of them doctors, some of them nurses as well.
Wonderful.
And Dr. Asha is planning to introduce palliative care in a much more stronger way in her place.
Okay.
So that is why she has brought in such a very active group to us, so
Okay.
that they could be get trained from us. That is the
Wonderful.
basic profile.
That's nice. Will do. Thank you so much. Now, if you look at those two quotes, if you just read them, the best way to find yourself is to lose yourself in the service of others. That's a quote by Mahatma Gandhi. The other one, remember that the happiest people are not those getting more, but those giving more. Quote by Jackson Brown Jr. What do you understand from this? Uh, we are referring to voluntarism here, actually. Uh, this has got a good relationship with voluntarism. Briefly, it actually sums up what voluntarism is all about, is it not? Yeah. So uh, there is no qualification required to be a volunteer. Absolutely no qualification, educational qualification. All you need is a good heart, a kind heart, filled with compassion and empathy for our fellow human beings. So that is the first criteria. Uh, I'm losing this often. Okay, got it. Can you hear me now?
Yes,
Hello, am
Uncle.
I?
Yes, you are audible.
Yeah, okay. So that's what it's about. And when we talk of, so what is palliative care? Before we come to palliative care, I like to tell you,
Yes.
okay, before I come to palliative care, I'd like to tell you what's it's all about. I mean, what is the basis of palliative care? It is, uh, it depends, it is to ensure our right to live with dignity. Article 21 of our Constitution bestows us on us our right to live with dignity. And though it does not talk about the right to die with dignity, by corollary, it also includes the right to die with dignity. Because so long as a person is not dead, he is still living in whatever state that is. So by corollary, it also includes the right to die with dignity. So that's what palliative care is all about. And Sangeet, can you come up with that PPT presentation?
Yes, sure, Uncle. Is it visible, Uncle?
Yeah, it is. The first one, which says Is there anything before this? Okay, that's it. The one, okay, next one. Just, So this only talking about labeling. No matter what you are labeled, it all depends upon what you actually do to society. What is the quality of our work? And what is our contribution for the cause and all that. So labels are not for people. It's only for clothing. And next slide. What is health? Health is a state of complete physical, mental, and social well being, and not merely the absence of disease or infirmity. It's a very good definition by who. So it's not enough if you are just physical, if you're okay physically or mentally, or one of these are present. Only when if you have all of these, then wholesome, you can call yourself healthy. Okay, next ones. Sangeet. What makes palliative care unique? Now, this is a very good way of explaining what palliative care is about by giving a contrast between modern medicine and palliative care. So you can see from this, modern medicine is disease-centered. It is disease-focused. Actually, the focus is on treating the disease. But in palliative care, it is person-centered. Now, to explain this further, if you were to go to then what is the normal scene that happens in a clinic or in a hospital when you go to a doctor? They examine you, they get various tests carried out, maybe lab tests, scans, and all those things. And then they diagnose what disease you're suffering from. And then they prescribe the required medication, okay? And they are done with that patient, and then comes the next patient, walks in. So that is all modern medicine focuses. Maybe that's all they can do within that limited time. But under palliative care, it's the person-centric. We need to go beyond the disease because modern person is not bothered about whether the patient has the money to buy the medicine. What other problems are they suffering at home? Do they have psychological problems? How the disease has affected the family? Is he worried about, or she is worried about what will happen to the person after he or she is no more? So, and also societal problems, the problem that they face in the society. So modern medicine is not concerned with all this, but under palliative care, it's wholesome care. So that is because it is person-centric. And so again, it says curative treatment. So modern medicine goes for curative treatment. So in palliative care, it's only when all remedies have been exhausted and the doctor says there's nothing more we can do, or we got to just manage the patient. It's not end of life care as well. So a person doesn't have to be in end of life to be in to come under palliative care. There are so many people who live a long life even in a crippled condition or whatsoever. So there's no cure there, but how do you manage their symptoms? That is the most important thing. So it's in palliative care, it's about symptom management. Sorry. Okay, it's about symptom management, and you can't see the whole screen. That's why I'm fumbling there. Symptom management and care is it? Okay. Now, the next one focuses on biological aspect. In the other one, it is physical health as well as emotional health and spiritual health. It's called total care. So only what the doctor sees on the patient's body, what is actually visible, only that comes under modern medicine. But what is hidden doesn't come under that purview. So that comes under palliative care. So you got to go beyond that physical condition to see what is the physical health and emotional health and social health as well as spiritual health of all these, of the patient. Because a patient will be suffering from all or any of these, which does not come under modern medicine. Now, patient and a bystander, if any, under modern medicine. Okay, you have a patient and you have a bystander. But in the case of palliative care, you don't have them. You have person with serious health issue and his or her caregivers, most of them are family members. So that is another difference. Under modern medicine, it's institutional care, where the care is given in an institution, like in the hospitals or clinics. Whereas in the palliative care, it's mostly home-based care, where modern medicine doesn't reach. Is that all in that page? The next slide then. So what is palliative care? WHO has described it as an approach that improves the quality of life of patients and their families facing the problems associated with health-related suffering through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So that you can see that the words underlined are very important. The quality of life. So it all depends upon the quality of life. How do you ensure the quality of life of patients? Not only the patient, but also their families. Because I said earlier that palliative care has come about mainly in recognition of our life to live with dignity. So the quality of life, how long a person lives is not important, but what is the quality of life with which that person has lived his life is more important. That's what matters. And it also not relate, it's nothing to do with end of life care. It only includes end of life care, but there's a lot of cases where even when there is no end of life care, like a person is a paraplegic, a quadriplegic, or suffering from any other ailments, they can live on endlessly, I mean, not endlessly, for a longer period, so long as their symptoms and all their worries and problems, like we mentioned earlier, societal, psychological, and physical, all these problems are addressed then. So that's what it's about. So associated with health related suffering, it has to be health related suffering, not just because of poverty or anything, but poverty makes all these problems worse, much worse. So the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. So it's actually a management of all these symptoms, what it's about, that helps the patient to live a life of dignity. That's it. Now, tip of an iceberg. This is a typical example of the contrast between modern medicine and the other one. What you see, what does this picture tell you? What you see of the mountain is physical illness, pain, and discomfort. This is visual to anybody. When you see a patient, it's visual. Okay. But is that all that a patient is suffering from? Next slide. Okay, but look beneath the iceberg. The one you saw earlier was an iceberg, but look beneath the iceberg. There's a lot more than you see at the top. So this is hidden within the patient, which is not visible to the person outside. You can see all the problems that the patient is suffering from: declining faith and hope because of his sickness, no money. He spent his money entirely on treatment. There's been many a family who have fallen from affluence to penury. Look at trauma, abuse, and violence that generated within the family, or by his own, by being dejected about the illness. Concern of family and family issues. What's going to happen to my family when I'm no more? Or there's no money in the family. If there was a wife or somebody, or either way, looking after the patient, or who had a job and had to give up her or his job to look after the patient within the family, there's no income coming into the family. How are they going to live their life? The natural consequence is that children drop out of school, isn't it? And when they are in debt, what happens? When they spend all their money on treatment, you have the creditors uh, chasing them. Where's my money? Where's my money? So all these are the problems that the patient and the family suffers from. These are all not visible to the outside world. sense of worthlessness. There is a dejection with the patient that he thinks, I've become useless now. I'm worth nothing now. I used to be earning so much. I had a very good life, dignified life. I'm good for nothing now. I become a burden on my family and on society. So this is a sense of worthlessness. Job loss, just mentioned before, job loss. Social rejection, societal rejection, because the normal tendency is for society or the neighborhood to reject a patient, um, not give them support, and all those things. That's another social rejection. Then caregiver fatigue. I'll come to caregiver fatigue much later uh, in the session. Now, because nobody knows, or the focus is always on the patients. So nobody ever really knows how much the caregiver is actually sacrificing his or her life to care for the patient. So that is caregiver fatigue, because they've got to look after not only the patient, the whole burden of running the family falls mostly on the woman. She might have lost her job, given up her job to look after the patient. She has to look after the patient. She has to look after the children. She has to deal with creditors or money lenders who have been chasing them. Actually, or worse still, when the patient is dead and the pillar collapses, the foundation is gone, and the whole world collapses around them. So these are all caregiver fatigues. Then declining mental health. Again, as I said before, their mental states becomes unstable. Sexuality issues, when they're not able to do things that they were able to do before, then these are sexuality issues again. Suicidal ideation. I cannot live anymore. I cannot undergo this suffering. I can't bear to see this. I cannot go through this. It's better I am dead and gone. So these are suicidal ideations. Hello, not done with it. Rejection by the medical profession. So this is also there. Sometimes there is a fear that if they don't get the right care, that they have been rejected by the medical profession. There are other symptoms and fears of worsening. Illness is not very clear. Fear of death, that's another thing. So actually, that's it regarding. So these are all physical illness, pain, and discomfort which cannot be visible to the outside world. It's all within the patient, but not visible. Okay, next slide. Illness-related suffering is much more than just physical distress. Like we said before, there are different aspects of pain. There's psychological pain. Physical pain is what we said before, that is visible. The what's lying beneath is psychological, spiritual. Psychological, the fear of death, then how are they going to live with the family, with this condition, and all those other problems, those are all psychological. Then spiritual is, sometimes they may feel that I've done only good. I pray so many times a day. There's nothing bad I have done. I lived a very, pious life all through my life. Why did this happen to me? Okay, they lose their faith in God. Okay, you don't exist. If you did exist, I wouldn't have to go through this. So that becomes a spiritual issue. The socio-economic issue, because some problems with society, as I said before. Then economic part, when there's no money in the family, they spent on treatment, they lost their jobs, and how they're going to run the family. This becomes a burden. Socio-economic situation. So this is all can be classified as total pain. Only when all these are addressed is palliative care complete. So palliative care needs to go into all these things in their symptom management and everything. So that's how total pain is dealt with. The next one. The typical, for example, this is just a case study. You see the patient now lying there, collapsed, sort of. So Ravi is a 25-year-old man who lives in a semi-urban area. 4 years ago, he had a fall from the construction site, following which he became paraplegic. Post-surgery, he has not regained power in his limbs. Doctors have told him that his condition is irreversible. He was also told nothing can be done. There is no use of coming back to the hospital again. He has been bedridden since then and has repeated attacks of fever and several bed sores. So, as I said before, and you look at the second point here, nothing can be done. There is no use of coming back to the hospital again. That is the stage when actually palliative care takes over. He has been, so under palliative care, they say all is not over yet. This is when our work begins. So he has been bedridden since then and has repeated attacks of fever and several bed sores. The wounds are foul-smelling discharge and are gradually increasing in size. He cannot lie supine comfortably. Next one. Ravi is a young man with a wife and an infant. He lives close to the city. He was the main breadwinner and in his present condition has to depend on his older brother for his family's sustenance. He is distressed due to his physical disability, pain, and repeated febrile illness, and is very distraught with the medical expenses incurred during these episodes with the local GP. He has also to travel a distant clinic for changing his urinary catheter. He had visited a spine specialty center 1 month ago looking for cure, but they too informed him that nothing more can be done to make him walk. They suggested he use an airbed. Now he feels isolated and a burden to everyone. He shuns company and refuses to meet even his old friends. He is also distressed by the foul smell from his ulcers. He is angry and feels that God has been unjust to him, especially when he interacts with others. He finds their sympathizing attitude most distressing. He is desperate to start earning, contribute to the family expenses, and get back to his role. See, though there is a feeling of uselessness in him that is good for nothing, and he's become a burden to his family and society, as I said before. So he's suffering from all these problems. He's worried, unable to sleep, and often considers suicide as a solution from this misery. Then he worries about what might happen to his family after he is no more. We summed up all these in earlier points as well. It is abundantly clear, I guess. Next slide. This is a repetition about what was stated earlier. A palliative care team, multidisciplinary approach. So under palliative care, it is not actually one team's or one discipline's role to play. Like in modern medicine, where you have only the doctors and others who are there. In palliative care, it's a multidisciplinary team. Everyone consults each other about the patient's conditions and plan what is best for the patient. So it involves a range of services delivered by a range of professionals that all have equally important roles to play, including physicians, nurses, social workers, psychologists, physiotherapists, and volunteers. You will see that social workers are excluded, um, especially physiotherapists and especially volunteers under modern medicine. They are not there. In support of the patient and their family. It's a combined effort of all these. Okay, next. How did palliative care start? A brief history. It goes back to 1967 when the palliative care was born out of the hospice movement. Dame Cicely Saunders is widely regarded as the founder of the hospice movement. She had degrees in nursing, social work, and medicine. She introduced the idea of total pain, which included the physical, emotional, social, and spiritual dimensions of distress that we said earlier. Saunders opened the St. Christopher's Hospice in London in 1961. This was the first hospice as well. Next. Father of palliative care in India. He is considered Dr. M.R. Rajagopal, Padma Shri M.R. Rajagopal. He is considered the father of palliative care in India. He was also the founder chairman of Pallium India and currently the chairman emeritus of Pallium India Trust. Now coming back to Kerala, 90% of the palliative care, or more than 90% of the palliative care in India actually is done in Kerala. Maybe because of Kerala's history of social activism or whatever, the movement started here initially. and spread now to the rest of India as well. Kerala started its first palliative unit in 1993 at Kozhikode Medical College in connection with the Institute of Palliative Medicine. They're still one of the pioneers in the area. In 1999, 4 NGOs, Malappuram Initiative in Palliative Care, Pain and Palliative Care Society Kozhikode, Alpha Palliative Care Unit, Clinic Thrissur, and Justice Sivaraman Foundation together constituted a community initiative named Neighborhood Support in Palliative Care. With the active involvement of volunteers, it paved way for community-level initiatives in palliative movement. Here, I'll also like to add about the NNPC, or Neighborhood Networking in Palliative Care, which is also started in the same place with these people and other, with Dr. Suresh Kumar and one more doctor who actually started that initiative. And what it is about bringing the medical community as well as the volunteers together to provide palliative care within the community. So they train the volunteers and to identify patients who need palliative care, and they refer the patients to the doctors. So it's a combined effort of the medical community as well as the voluntary volunteers within the community who address the situation with regard to the patient. So that's called neighborhood network in palliative care. Then, adding momentum to these community initiatives, Government of Kerala framed an official policy, Pain and Palliative Care Policy, in 2008. So Pallium India actually was the one who framed this palliative care policy for the government. They have representatives from other government representatives as well on the body. And this is the policy being reviewed every 5 years and improvements made to the same. Next one. Now, need for home care. Why do we need home care? Physically unfit, unable to travel. Because this is not available under the modern medicine. As we said before in the contrast, it's not available there. Why you need home care? Physically and unfit or unable. When a patient is physically unfit and unable to travel, especially when in a place like Trivandrum or living on the hills where it's very difficult to have find a transport to take them to a hospital, which may be again far away, then they need home care. No one to bring them. So there's no one to bring them as well. Sometimes the caregiver may be, it may be difficult for them, or there may be children. So there's no one to bring them. They have to depend on volunteers and their neighbors. The financial strain. They already, if they had money, they already spent it on treatment, and they are broke. So they're a pauper now. So that is another. They don't even have money enough to earn their daily living. So how do they go to a hospital? So that's a big financial strain as well. So that is why they need home care. Next one. Then the road conditions, like the outskirts of Trivandrum, and especially in the north also, the people living in the hilly areas or tribal areas and all those places, the road conditions are very bad. Sometimes there are no even steps to climb up. It's a very steep gradient and very risky, even for a normal person to walk. So the question of bringing down a patient is also ruled out. So walking distance to get to transport, or they have to be carried. So these are all the obstacles that come in their path. Next slide. Components of home-based care. Physical care. Physical care is also given in the home-based care. Then you get emotional care also. Like there are psychologists and counselors who will address the patient's problems and give them solace. Okay, how they can overcome those problems. And there's social care. Social care, even the community gets involved. So the community, through volunteers, they take care of the person's need also, as far as they can. So there's a role to play for everybody within their limitation. There's a lot they can do. So there's social care. So spiritual care is also given. So when a person says that he's lost faith in God, there's no God. If he was there, I won't be having to suffer like this. So how do you address that concern? How do you pacify them? How do you console them? It's nothing to do with that. Okay, this is just a medical condition. So that is the spiritual care. And next slide. What are the benefits of home-based care? A patient and family feel support. Okay, they are not alone in their suffering. They know that there are people who will walk the talk with them, who will hold hands with them. Patients receive individual attention, but it's not possible in the modern medicine on the general setup. Less social isolation. So the community becomes supportive of them. So there's no social isolation anymore. And this is where the volunteers can play a role to get the society together to support the patient. Full assessment of patient and family. A full examination and assessment is done, not just physical examination. In fact, it is said that one needs to be a good listener. We need to give the patient a lot of time to let him pour out his woes. What are his sufferings? We need to be a patient listener to his problems. Only then we can address his requirements. Now, patient remains part of the family. So if he felt dejected or anything and he is lost what do you call connection with his family, and once these problems are addressed, he becomes a part of the family. His faith is restored. Now, understanding of family dynamics. So when you go in depth into a person's background, the patient's background, then you come to know whether there are any other problems that he's suffering from, like interpersonal relationship within the family. So you get to know all those aspects only if you go to, because these are also problems that he's suffering from. How those can be addressed is another thing. Now prepare patient and family for any anticipated difficulties and symptoms. So how do you address the patient if his it's going to be end of life, or his disease is going to get much worse. In fact, even when the patient's what do you call uh, patient is being examined and in depth, then details are acquired from the caregiver or the patient. How much do you know about your illness and all that? And so how to address that pain? Sometimes if he doesn't know, if he's ignorant or something, it's rather let it be that way rather than make him think about his worsening condition, making his condition worse. So then the caregiver is taken into confidence and told what to expect, but not to worry that his symptoms will be managed. Okay, so there will be no suffering, that kind of thing. So prepare patient and family for any anticipated difficulties and symptoms. Next one. How you can help. We think of the volunteer, how a volunteer can help. Now, as I said before, what is the qualification to be a volunteer? All one needs is to have a good heart, a kind heart, full of empathy and compassion. Okay, even a child can have it in that. Though he or she is just a child, any other person can have it. Don't have to be literate or anything. So, and you don't need to have money if you want to be of help to anybody, because there are so many ways one can always address these problems. So money is not one of the factors. Finding opportunities to help patients, palliative patients and caregivers. There's plenty of opportunities also how you can help them. We'll come to it later. Assisting with activities. Various activities there are that you can help them with. Spend a little time with them. Like you see, loneliness itself is a big problem and a cause for suffering. You know, some people may not be having any major disease or anything, but that loneliness, Sometimes the children have neglected them or not in touch with them, or they are far away. So that itself creates a mental situation. I don't know what is the medical term for it. There's a term for it. Um, and so all they need is someone to come and spend time with them. There is a short video here, but that is in Malayalam. It's taken from a movie, just a 1 minute thing. Uh, but, I don't know if you want to watch that or anything. I'll just tell you about that. There's a lady, young lady who comes, there's an old lady who is living by herself alone in a small dwelling place, hut-like thing. And then walks in the heroine, a young lady, who walks that way, come to her house. And then she tells the old lady is wonderstruck, and she asks her, "Oh, have you lost your way, or did you intend to come here only?" And the young lady says, "Oh, no, not at all. I wanted to come here only. Why shouldn't I come here?" Then she said, "No, no, you must come. I'm very happy that you came." Then she says, "Are you okay? Do you need help to go to the hospital or anything?" And the old lady says, "No, no, I'm okay. I'm fine. No, not. I can manage that myself. But this lonely life, this is taking a heavy toll on my health. This is terrible," she says. "If only I could have someone to talk to, that would make a big difference. Now, see, you come and met me now. You made me so happy. You made my day. Do come often. See, how much time did it take for this person? Did it involve any money? No, not at all. Even a child can do that." So this is what we meant by saying spend a little time with them. Another, next one. Okay, we're coming to the end of this. It's hello, just a moment. Yeah. Okay, I myself was baffled what this is about until the what you call the producer Reena told me what it meant. This is a boy and his father here. They're picking up, the father is doing something, and the boy is picking up starfish that was washed ashore. He's picking them up and putting back into the sea. So his father asked him, "What are you doing?" So the boy says, "I'm saving them actually from dying." So the father said, "But how many? There's so many of them. How much can you save?" He said, "I'll save as many as I can." So the boys got such a good heart, no matter what. So if everybody puts in their collective effort, surely they can make a difference to the families of people who need palliative care. I think this is over. And is that over? Done. Okay. I would just simply have the time from my experience, 12 years of experience in palliative care. I can tell you some of my experiences actually. We provide care to 95% of the care that Pallium India provides is to poor people below poverty level. There was one case where when our team went to a patient's house, what we do is normally we give them um, medication only to affluent people. We give medication because the patient's house was, with marble flooring and deep carved windows and all that, and two-storied house. They didn't ask what is the thing, background of the family. So they just gave the medication, not medication, the prescription to buy the medicines. About 2 weeks later, when they came for a review visit and found the patient's condition worse, they asked the caregiver, "Have you not given them any medicine?" The patient, the medicine we prescribed. So the caregivers broke down at the time. She, she started crying like anything. And she said, "You don't know, daughter, our real this thing. There was a time when we led a very affluent life, and after my husband got this stroke, then they went to helter skelter, going for treatment to various private hospitals, spent all the money they saved. They were in debt actually to around 20-30 lakhs or something in debt. Now they said, "We've sold everything we had. Now we don't have even money to buy food for us." She started weeping. And then the nurse said, "Don't worry, we didn't know about it. Please don't worry. We'll take care of all your needs." So this is an example. And then we rehabilitated the family, and they are very well. They are much better now, much far better now. So this is a typical example of where, affluence can bring down a person to penury by uh, exorbitant costs on treatment. So this is just one example. There's a lot more uh, examples that I can say during our lifetime. There are a lot of lessons to be learned, when you are a volunteer, when you go out in the field, you actually need to go out in the field to know how these poor patients live. That is when actually it gets into you get really sensitized actually. When we live in our ivory towers, we don't know how the rest of the world is living. It matters because we need to count our blessings, because it only takes a fraction of a second for your fortunes or your blessings to take a tumble. It only takes a moment. A person may be thinking that some people, I don't know, like Hindus, we say that if a person is enjoying one's what do you call life or fortunes, and then it's due to our previous karma or whatever in the previous birth and all that. But the next moment, if that takes a tumble, then where is the answer? So those kind of things. So one must always be conscious of one blessing. Like another example, take cancer. Okay, a person gets cancer. Does it comes with an advance notice or a thing? No. All of you, you find a small lump or something. You ignore it. Then you go for treatment. They take you to cancer center. It's confirmed it's cancer. Then what? If it's third stage and there are no hopes. So what did it take? The person has done nothing to get cancer. So it doesn't take long. So we need to always be counting on our blessings. Yeah, Dr. Asha, that's good exactly what you said. So we need to share our blessings. That is the only thing that makes our life worth living, actually. One can actually be proud of that. So this is another thing. The another lessons that, the humility, the suffering that they undergo. That is another thing. uh, when we get a small cut or a wound or something, we go haywire like this. Oh my God, it's intolerable. But the suffering which they are enduring, that's a big lesson for us. They're going through that. Sorry, anything? Hello. Okay. So that is another thing. Humility. I've seen when I go on patient visits to very poor people who don't have even money to buy the food. They depend on food from their neighbors who provide them food, living on hilltops. If I take out a 1,000 rupee note and say, please accept these from this from me, they won't take. With folded hands, no, sir. Then somebody has to put pressure on them, their neighbors. Please accept. Sir is giving it with good intention for to keep me happy. Please accept. Only then will they accept. So these are a lot of lessons that we learn when we go out in the field. One must be going out in the field as a volunteer, because you get a sense of feeling that no matter how much you contribute, you get a feeling that you haven't done enough. You need to do a lot more. So that's the kind of satisfaction that you get out of it when you are really serious about your work and all these things. I can tell you another thing about, because these are things that one should know, which is not in the PPT. Like we earlier talked about caregiver stress. Okay, now it's recognized that more than 80% of the caregivers the world over, not restricted to India, are women. Happen to be women. Okay, but the focus is entirely on the patient. So the caregiver or the woman who lives a hidden life. How much of sacrifice the woman is undergoing to keep the patient in that condition, in that good condition, free of suffering and other things, uh, is actually to the credit of the woman. But it's taken for granted. At least they could be given their due, what you call, credit for that role. So that's why Parliament had come out with a documentary funded by FOMA. It's called Support a Different Story. Uh, do we have that, Sangeet? Sangeet,
Yes, sir.
do we have that Support a Different Story? I don't think, no?
Oh, no, no, no.
Not
Aspect
there.
3 7.
Okay, okay, fine. So that's a very good documentary if you can find it. We've taken only 5 cohorts we've chosen. There are so many of them. The role that they play in making sure that the patient lives a dignified life. One of them I can tell you from memory. I can tell you. Okay, fine. We'll arrange that. Okay.
Yeah, I can share it with the learning materials along.
Okay. I'll tell you one of those. Actually, there's a patient who became a paraplegic, young patient only, maybe in his early 30s or something. And so he had lost body movement below the limb and all that. So he had to be turned in bed often, so that he doesn't get bed sores. And what his wife used to do is that she used to set an alarm. Yeah, wonderful, Manasi. Thank you. She used to set about 3 alarms at night, probably 3 or 4 alarms at night to wake him up, not to wake him up, to turn him in bed. Okay. And early morning after she wakes up and she wakes up the patient, what she does is she wheels him to the courtyard of the house and then gives him dumbbells in his hand, the weight, they carry the weights, and ask him to do that exercise. And after that, she again takes him to a small podium-like thing where she ties him up with a rope to make his legs strong. Just stand there in that position to make his legs strong. He's given a clean shave. So if he doesn't, with a beard, so if he were to sit in front of a table, you'll never say that he's a patient. He looks handsome guy. Hello, can you hear me? My interconnect connection is unstable, it says.
No, I can hear you, Uncle.
You can, okay. So that is the thing. Then after that, she has to send her daughter to the school. She has to take care of her in-laws. Both of them are patients. One is a cancer and one is a stroke patient, I think. Take them. At 11 o'clock or something, she goes around from house to house selling garments. Then she come back for lunch, feed these people, receives her child from school. And she's doing so much, actually. But she's leading a hidden life. Does society ever know the what do you call, the sacrifice that she is doing? So there's another lady who is old parents actually. They are probably in their 70s plus. Okay, and they have 2 children, one boy and a boy and a male and a female. They're in their late 30s or something. Both have been born crippled actually and totally bedridden. They can't do anything on their own. They have to be helped. So when the lady was asked, how do you manage all this? When they were children, you didn't have a problem with them, isn't it? They were easy to handle. Now they're so grown up now and you're getting so old. Are you not worried what will happen to you? What will happen to them when you're no more, when you're gone? And the lady said, I don't think about all those things. I think that this is God's sent. Okay. This is for me to accept as God's, what do you call, Hokamasam. That's the way it's meant to be. So I accepted it. And he said, this is what is keeping me healthy. Looking care of these children is making me healthy. I don't have diabetes. I don't have a heart problem. I don't have anything. She's busy doing her job. So look at the spirit with which they are talking. Look at their acceptance and how they are accepting with grace. So these are the lessons I wanted to say that we learn when we go out there. When we live in our ivory towers, we know nothing about all these things, about our blessings and all that. So I can go on and on and on. It will take a long time. There's so many things to say. Another thing I would like to tell you about is what is that? Yeah. Now, stemming from this Article 14 of our Constitution, which gives us the right to live with dignity, a new legislation has been brought up by the it's called the right to live with dignity, not right to live with dignity. It's called the Advanced Medical Directive or the Living Will. Have any of you heard of it? The Living Will or Advanced Medical Directive. So this is that under this provision, any person when his faculties are all right, not when he's a patient or anything. When his faculties are all right, he can take a choice, make a choice. It's a will actually. He can make out a will like a property will, like any property will, whereby he says that if at any time at a future date, if I were to go through an incurable disease, okay, thank you. If I were to go through an incurable disease and the doctors put up their hands and say there's nothing more that we can do, then and if they were to put him in ICU or have any such interventions where it is hopeless, then he can make out a will saying that I do not want to go all through all this. So if they are in ICU, he's giving them a right to pull the plug, okay, because he doesn't want to, he wants to live or die a dignified death. They don't want to go through suffering. So that is a will, and once that is he has done it, then that becomes, it's legal, that is law. But another thing that's important to note is like with legislation alone is not enough. A lot of advocacy is also required, because family members or others can always, throw in the spoke by saying, spoke in the wheel by saying that uh, why did you resort to this? When you're stingy, you didn't want to spend your money. You've got all the money, but it's a matter of the patient's right to live with dignity. He doesn't want to be living in that state with all those tubes and wires going, just hardly living with no hopes at all. So they have granted that will. That legislation has come. So it also needs advocacy to let people know what this is all about. It's for the patient's benefit actually that is being done. This was in the pipelines for a long time, but the government was keeping it in abeyance because of the fear that it could be misused. Like with like the NDPS Act and all that about morphines and all those narcotic drugs. So it took a long time coming. But another thing that I want to talk to you about. I think it's about it. Anything else? Any video that we can share? What is okay, coming back. Hello, can you hear me?
Yes, uncle.
Hello,
Yes,
am audible? Yeah, about when, because the main session is about voluntarism. Voluntarism will succeed only with community support. There has to be community involvement, as we mentioned there, even in NNPC, neighborhood networking palliative care. We need to have the medical team as well as the community. So we need a community involvement very much. To address societal problems as well as other problems that the patient is facing. They can do a lot. They can bring about a big change. The volunteers. So there are a lot of things that the volunteers do. I'll show you the screen, share the screen later. And so volunteers play a very important role in this thing. That's why this training and everything is required. Formal training. In North Kerala, they do a lot more job. The volunteers, unlike in South Kerala, in the North, they do a hell of a lot of more work. They actually run even scan centers, dialysis centers, labs, and all. Even college students, Farooq College in Kozhikode does it, and there's a lot more activity going on there. So that is another thing about volunteerism. Then I talked about neighborhood networking in palliative care. I will show you a story, not a story, in a cartoon form to explain the concept of this thing, neighborhood network in palliative care, and how volunteers play a role in the community, how they can set up small groups that work in collaboration with the others. Can you play that one Bill story?
Yes, uncle.
That was a nice video, wasn't it? Hello?
Yes, uncle, you're audible.
Am I audible?
Yes,
Hello?
uncle.
Can you hear me?
Yes, uncle, you're
Yes,
audible.
yes.
Hello?
Yes, we can hear you, sir.
You can? Okay. Yeah. So, okay. I just like tell you about what volunteers they can do. sitting, attend registration. Apart from the medical condition, I mean, other things like socio-economic situation and all that, and what is their condition, if they have any problems and all that. So deserving cases, we recommend, like vocational rehabilitation for them. Counseling is there. We have a bereavement support group for those who are, like when a patient dies, if it's a male or whoever, it's like the central pillar of a building collapsing. The whole edifice collapses. They don't know how to get on with their life. So when you have patients who have already gone through this phase, they become part of the group, and then they provide solace to the to the surviving members, recent surviving members, that we've gone through this phase, not to worry, life will go on and all that. So they provide that kind of encouragement. So that is the bereavement support group. Then we also spread awareness within the schools and colleges to help patients, like if they want to do any cleaning up, or put up some temporary shelters over their head, leaking roofs and all that, or raise money for food kits and all that within their community or within their school or organization and all that. So they raise money to provide free food kits and all that. So a whole lot of things that the society can do to alleviate. So that is why it has to be a joint effort within the community to make palliative care a success. I think I've spoken a lot. I allow some time for, one can always go on and on. So it's question session. Like, can you have any questions? Hello? Can you hear me?
Yes, uncle.
Anybody like to ask any question?
If you have any
Hello?
questions regarding the sessions.
Good evening, sir. This is Dr.
I
Asha
don't hear
Deshmukh from Nasik.
anybody.
Can you hear me?
Ma'am, you're audible.
Good evening, sir. Can you hear me, sir?
Sangeet, can you hear me?
Yes, sir.
Can you hear me?
Yes, ma'am, we can hear you, ma'am.
Yeah, I can hear you. Please.
Yeah. Sir, can you hear me?
Hello?
Sir, can you hear
Hello?
me?
Dr. Deshmukh, we can hear
Hello?
you.
Now I can, yes.
So I just wanted to say that, as you rightly said, that once we go into, service, and we actually start working, that is when we will actually understand the exact essence and flavor of palliative care. So we are waiting to be volunteers soon.
I think he's rejoining now.
Yeah, so I was just saying that, as you rightly said, there is much to learn when you are on field. So once we actually start working, that is when we can appreciate what the essence and flavor of palliative care actually is.
Yeah. Sorry, say that
Yes.
again. I lost you. Once again, please.
I said, as you rightly pointed out previously in your talk,
Yeah.
we can appreciate what the essence of palliative care is once we actually are on the field and working together as a unit.
Exactly. You're very correct.
Yes.
You're very correct.
Yes.
Yeah. In fact, even, when I used to go for fundraising, and I used to walk into a doctor's house, for example, I mean, both of them are doctors. And when I start talking about palliative care and all that, I tell them in between 2-3 times, if you're getting bored, please tell me, I'll leave. But they tell me, no, go on. It's very interesting. So it's a new learning even for doctors, actually, the palliative care. In care.
I think his screen is
At least
frozen.
many of them heard, they know what it's about, at least on the fringes they know.
Until your voice is breaking.
Anyone else? Hello? Hello? Can
Yes,
you?
Uncle, you can hear it. Yeah, now it's audible.
Hello?
Yes, Uncle, we can hear you. Oh, there are some comments coming up. Thank you, Manisha Acharya. Thank you so much.
Hello, can you hear me now?
Yes, Uncle.
Yeah, I'm losing connection in between. Okay. Any more questions? Hello?
Hi, good evening.
Yes,
Can you hear
ma'am.
me?
Welcome.
Yeah, good evening, sir. This is Neha from Kerala itself, Kollam. I have a doubt
Can you
actually.
speak a little louder? I don't know if I have a problem here. Please.
No, no. Hi. Am I
Yeah.
audible now?
Yeah. Okay. Tell me.
Okay. Yeah, so I have a doubt. Actually, we have families here with people having illness like severe autism or Down syndrome. For
Okay.
such people, like their life expectancy is much more than other like cancer or other incurable diseases, right?
Yeah.
But they're in lower economic status, people with lower economic status, their life quality is much lesser than the families having these type of patients in the upper financial state. Their life quality is much more, much worse, and the people who are giving care for them, they are also suffering.
Yeah.
So those patients and those families come under, whether they come under the palliative care or not, because their life expectancy is more.
Yes, definitely they come under palliative care. You see, the thing is, if you see the definition of palliative care itself, it's to do with serious health related suffering. Anybody suffering from serious health related suffering is qualifying for palliative care. It doesn't say that only such and such a disease qualifies for palliative care. The yardstick is actually this particular terminology that I use. That is the quality. But there will be lots of many diseases or ailments. Practically, they have not been what you call coming under palliative care for want of resources or something. If you have everything, but they are all eligible. You understand? They're all eligible. Because take for example Parkinson's or what do you call the loss of memory, Alzheimer's or anything. So there is no what do you call their life expectancy is a lot like the one you mentioned, isn't it? So all those are under
Yeah.
palliative care. But normally we always hear about cancer, paraplegics, and stroke patients and all this, isn't it? But there's a whole lot more that comes under palliative care. Is that
Okay.
clear?
Thank you, sir, for the answer. And one more thing, what is actually the maybe that is not a good question, but I'm anyway asking, what is the difference between hospice and palliative care,
Hospice and palliative care.
or is it the same?
No, it's the same actually.
Yeah, hospice
Palliative
and
care is only the treatment or the type of treatment that you adopt, okay? The care that you give. They show you the contrast between the modern medicine, what normally hospitals, and then coming to home care. Hospice is similar to home care, but it's not in your own home. It's like a hostel. I don't know what you call the hospice. We don't have much in India. It's mostly abroad. You find hospices in Europe and other places where
okay.
it's a large place where all mostly geriatric patients live. So they get the attention. There's a lot of greenery around. Like you call what is it called here? It's like a sanatorium, no health. What do you call? No such places, no. Like in the hills, you have no closer to nature and all that. A large setup, a large place with a lot of space around. But you don't have people, you don't have caregivers at home or anything. So you go to a hospice center. It's not like a hospital, not like a hospital either. You get it? So that is hospice.
Okay.
So actually the terminology
Okay.
is together. If you look
Yeah.
like European Association of or whatever, it comes a hospice and palliative care movement when you say they're linked. Hospice is only the setup,
Okay.
the physical, the place. Yeah.
Okay. Okay.
Any other?
Thank you, sir. Thank you.
Anybody else?
There is a question in the chat box. If
What was the question? If this
If this
was
was-
this, which one you mean? Which phrase you mentioned? If this you mentioned, you talking about hospice or? Why did it take so long?
Hello?
Yeah, yes,
Hello?
Manasi, tell me.
Yeah. Sorry, sir. I'm traveling. That's why I was just writing.
Ha.
No, in general, I wanted to ask that why it has taken so long to. I mean, I'm first in my family to actually hear about this.
About which
And
one?
I've
Hospice or
already.
palliative care?
Hello?
About which one?
About palliative care.
Okay.
There is no awareness or little to almost none awareness about. So I've spent 30 plus years and I still haven't spoken with any of my friends about this or I mean nothing in conversation and
Yeah.
I met with Dr. Asha and I had this conversation that there is something called palliative care. I'm a working professional in NGO sector, so that's why with an interest I joined here. But I just wanted to understand why there is still a lack of awareness. I mean, was it not bought into health system or the conversations around it is very.
Hello, can you hear me?
Yes, I can hear you.
Okay, actually, the movement started long ago in Kerala, especially. It's made a big impact. Actually, if you go especially to North Kerala, I was recently there for an IAPC Kerala this thing function workshop, and there I got into any bus or an auto rickshaw or anywhere, and the guy he knows you're from outside that particular place, and he asks you, so what brought you, and you tell them, no, I come here for a workshop or function. What's it about? It doesn't palliative care. And then they say, oh, palliative care. Oh, they know immediately that it's palliative care. So they're all very involved with palliative care, actually, the community. That's why we need to spread, by this advocacy only, we can spread the message, okay? And we start this actually from the school level, high school level. So 10th, 11th standard, 12th standard, and college level, we give them this. At least they'll grasp a little bit of what it is. Okay, so for elderly people, it's through residents association. All that.
Right.
You have to bring in the
Because
subject. Actually.
I work with schools. I work with schools in Mumbai, and I think there is
Okay.
hardly any conversations around this
Hello?
in the schools that is happening.
I think lost her because of the traveling net connection.
Hello? Hello?
Yes, ma'am, we can hear you.
Yes. I said I've been working with schools in Mumbai, and I think there is hardly any conversations around it. And you rightly said that it has to start early. The advocacy has to start early at the school level, or college level. It has to start early. This conversation, then this communities will build up. Am I audible?
Yes.
You hear me now?
Yes. Okay.
Okay. Anything else? Hello?
She just asked a question.
Mansi was saying something she couldn't complete.
Could you please repeat, Manasi?
Yeah, should I repeat?
Yeah. No, I thought you had something else to say. You're working in somewhere, you said Bombay and...
No, I said I've been working in schools and
Ah,
in Mumbai schools, and
okay.
there is hardly any conversations around palliative care or in
Ah,
healthcare in general. And you
okay.
rightly pointed out that there has to be an early stage advocacy at the
Yeah.
school level, at the high school level, where these communities starts
Yeah,
to grow. Yes.
exactly. You're right. That's true. Exactly. Any other questions from anybody?
Hello.
Hello, yes, please. Mr. Binu,
Yeah.
please.
Yes.
Welcome.
You as a chartered accountant could be into the field, and you found a certain way to be to
A
help.
little louder, please, Mr. Binu. I think my...
Yes.
Ah,
Am I audible? Am I
yeah,
audible?
no, problem with my mic, I think. Yeah, okay. Yeah.
Yes. You as a chartered accountant could get into the field. You got
Yeah.
into the field. You found a certain channel to help
Yeah.
the care.
Yeah.
Now, each profession could have something to give in some form,
Mm.
right?
Yeah.
I am a teacher by profession.
Okay.
Okay.
Yeah.
So, how could we understand that? How can I mean, yours we understand.
Yeah.
As a teacher, how could I be of some purpose over there?
Yeah.
Could you
See,
elaborate? Yeah.
ah,
Yes.
see, as I said in the opening statement itself, what is the qualification to be a volunteer? Okay. You don't need any educational qualification, right? It doesn't nothing to do with your profession, right? All you need to do have is a good heart, full of sympathy and compassion or empathy towards your fellow human beings, right? So, as I said again, we never know when our blessings or fortunes are going to take a tumble, right? So, we need to be filled with gratitude and give back. So, I was a chartered accountant, but much later in life, probably I began to realize that when I was 58, I started thinking, why am I so blessed? What have I done to be so blessed? Nothing. It's not due to my abilities, okay? Not because I studied well and became a chartered accountant, or I had everything going good for me. I was simply blessed. I don't find an answer. I don't even believe it's God, anything to do with God. In that case, then why are people who are, far more efficient than me, either they've dead and gone before me with some illness or something, or they're still crippled and leading, that kind of life? What have they done to deserve that? Nothing at all. So I thought it's payback time for me. So I gave up my job. I wasted 2 years picking the threads regarding my personal matters. But my conscience was always pricking my conscience that I haven't done anything yet. So then I started searching for many NGOs. So I thought it's either now or never. I started looking for any NGOs where I could be of use. It was just a chance meeting with a volunteer of Palliative India who told me, why don't you? I didn't know the person even. Why don't you join us? We are into palliative care. So I said, what's about that? I studied more, Google to know more about palliative care, and I found that so impressive, appealing. Maybe due to my advancing years, I'm 72 now. Maybe that's the reason. So then I feel so blessed. Then I made up my mind, okay, this is where I want to be. So it could be for any social cause, just that I happen to be working for Palliative India, palliative care. Your profession or your qualification, nothing. It has nothing to do with that. You know. So the fact that you join this course is you have a lot of empathy and compassion in you, which is why you joined the course to become a volunteer, right? So hats off to you. That's a very good start, Mr. Binu. Anybody else?
Momina has raised her hand.
Hello.
Yeah. Okay, just the two questions were being asked. Just I would like to respond on the two questions.
Yeah.
One, the person said she is a teacher and how it could be incorporated in the schools and colleges. I'll see, even I am a teacher.
Yeah.
And in my college, as a NSS program officer, we made it a compulsory training for the students, and
Yeah.
they were expected to do certain hours of work in the palliative care. So
Okay.
that way, once they start doing it by themselves, they become compassionate and get attached. They don't live after that also. They continue this palliative care. And secondly, one person said that he's a chartered accountant. Here, I feel profession doesn't matter. The compassionate heart and the gratitude towards the Almighty that we have everything and how we can give something to the society, to someone who is in need. That is very important. And I think so we all have that in mind, and that's why today we are together in this workshop.
Exactly, you're very correct. In fact, at school levels, what we do is we start from 11th and 12th, the final last 2 years of school. We start with that. And we don't talk to them in detail actually about palliative care. We just at their level, what they can do. We just talk to them about the fringes because they are too early in life to know what palliative care. The basic thing is to sensitize them, to be of good to society. Like you tell them that you don't think that you cannot contribute because you are children, just mere children. Like I told you about the video in which that young lady who comes to meet the old lady who is suffering from loneliness and all that. So like don't you have people in your neighborhood and all that who are in that situation? How happy they'd be if you went and spent some time with them. There's not, or maybe you could help a poor family who is next door, who are starving. Share a little food with them. That's another big help. So long as they know that they are not alone in their suffering, they've got hands to support them. That itself will bring a big turnaround in their lives. So, and as the children grow up, once they are sensitized, it happens automatically to them. Like now, for example, I'll tell you, in my situation, whenever I go for my evening walk, and I see old ladies or old people hawking vegetables or fish in the late hours in the evening, then I start thinking in my mind, why are these people at this age doing these things, but otherwise it's a normal sight. So they should be having some problem in their home. They have a patient or their children not looking after them. So when you are sensitized, automatically your thoughts will go to that level. Like recently I met a person. These are all lessons to be learned. He was in his 90s and he was dark and with no shirt, with just a loin to cover his bottom. And then when I see him pushing a bike when there is a gradient, and then he rides it when it is a slope or level. So when he stopped his bike, I asked him, I've been watching you for many days. Could you tell me what you do? If you don't mind, please, could you tell me what you do? And he told me, I asked him, how old are you? He said, I am about 90, like he doesn't know exactly. So then, what do you do? He said, I pick up, wasteboard. What do you call this? Actually, we say, pick up rags. Like I said, at this age, how much of rags can you pick and sell? Then he said, what did you do before? He said, I used to climb coconut trees and pluck coconuts. That was my job. Even now, when I see the tree, I worship the tree, he said. So I say, is there so much pressing in your house, in your situation, that you need to be doing this activity at this age? Is a wife okay? She patient or the children not looking after you? Said children are okay, but my wife is also not so bad. She's got minor problems. Then what? Then he said, if I live at home, if I stay back at home, I'll be bedridden. He says. He says. So that is why I am just doing this activity so that I don't get bedridden. I don't get laid down. See, that's a big lesson for us to learn, isn't it? And that's the kind of life he led, that even at 90, he survived no COVID, no nothing. He got immunity. He's a very poor guy living in a small hut, man. So when you are sensitized, when you see such sights, it immediately impacts you. So that's what I wanted to tell you. Yes. Hello? Can you hear me?
Yes, Uncle. Yes, Uncle. You're right.
Yeah. Anybody else? Any questions? Hello? If we have the time, I'm okay. Anybody else?
Okay, before winding up, is there anything anyone wish to say something? Okay, I think that's the end.
That's it?
Yeah. Thank
Okay.
you.
Thank you all for listening. You've been a wonderful audience.
Thank you.
Okay, wish you all good luck. Take care. God bless you all.
Thank you. Thank you so much. And thank you all for participating in the session. Thank you. Thank you very much. Let's see you in the next session. Bye.
Bye.